Hello everyone, thank you all for joining. We're going to be presenting a lot of imaging cases with the cath correlation, and for the sake of time I'm going to go ahead and start. This is for you to scan. Don't run. All right, so I'm going to go ahead and start with the first case. It was a 68-year-old male smoker with a history of colon cancer and remission, hyperlipidemia, prediabetes, hypertension, and with a strong family history of premature CAD, who presented to our clinic for 1 month history of recurrent episodes of chest pain. His EKG, as we can see, showed sinus rhythm with LVH, mild QRS widening, and secondary ST changes. On echo, we can see his LV size looks normal LVEF, no apparent wall motion abnormalities, and the RV looked good. He had no significant valvular disease either. So as per our ACC guidelines for patients with stable chest pain and no known coronary artery disease, and since this patient is intermediate to high risk, we decided to do stress testing with stress PET, which has a class 1 indication. Those were the PET MPI images. For those of you who are not familiar with this, we have the short axis on top and
Can you move the mouse cursor to the far left so you could
far left.
on the screen?
Oh, okay. So the short axis here, then the horizontal long axis here, and the vertical long axis here, and the stress is on top and the rest is on the bottom. Anyone thinks there's any perfusion defect? Ryan, any perfusion defect?
Is there like in the lateral and inferior wall on the side? Not what I can see.
Yeah, don't think there's any apparent one. Let's look at the gated images. See, it's all contracting well. No visual TID. Now looking at the flows, we can see that this is, can you see what? So this is the stress peak flows in the LAD, CIRC, and RCA territory, and this is the global. And we can see that they are all within normal ranges. And when we divide this by the resting flows, we get the myocardial flow reserve, which had a total of 3.21, which is totally normal. And since we calculate the calcium scores for all patients who need that while doing our PET, we did it for our patient, which had a calcium score of 1,426.
Sorry, question. Is the resting flow abnormal or low in this patient?
I think it's within normal, 0.6. So now the patient obviously has a high calcium score, normal PET perfusion imaging, normal flows. However, he continuously complained of persistent chest pain on exertion. So the next step was to do a coronary CTA for further evaluation and to confirm that he has no obstructive CAD.
How confident are you have this kind of evidence that this is completely normal stuff? Or what's the chance of missing obstruction?
I feel there's maybe like I would say 90% confident that I won't be missing any significant obstructive CAD.
Even more than that, I mean, when you have very high peak flow, you're very confident that this is the
Okay.
The peak flow was normal, even in the presence of high calcium scores.
Okay. So next, we did the coronary CTA. I'm going to share the axial images first. We can see there's diffuse calcified and non-calcified atherosclerotic plaque present with diffuse disease. Let's go over vessel by vessel. So the left main we can see has a mild calcified plaque with mild 25% stenosis. The LAD also has mixed plaque with, this was read as around 40 to 50% stenosis in the proximal segment and around 25% in the mid segment. The first diagonal was also read as having around 50% disease in the ostial segment. The left circumflex was basically free of any significant stenosis. And the first OM was read as having severe, more than 70% stenosis in the proximal segment. And the RCA, we can see here in the mid segment, there's severe plaque, and it was read as having 60 to 70% stenosis. So now we have a PET that is completely within normal except for the calcium score. And we have a coronary CT angio done with high resolution with the photon counting scan showing at least severe disease in the RCA and the first OM. So what would you do next? Anyone?
So this is through disease. Is there any explanation why it was not picked up by the PET scan?
If this was true, yeah.
Because this is hemodynamically significant. PET is obviously not anything, but what would be the potential explanations why this is not showing in the PET scan?
I mean, we can't blame it on balanced ischemia, right?
Exactly, that's the point. It's not balanced ischemia because you don't have disease in the
Right.
So the most severe lesion was the OM1, and I think the LAD was non-obstructive.
Right.
The RCA had the moderate lesions.
It was read as 60 to 70, yeah. So the next step was to look at the FFRCT. The FFRCT coded positive in the RCA, 0.8 in the mid segment, 0.76 in the distal segment, didn't call anything in the circ or the LAD hemodynamically significant. So now who thinks we're going to find significant disease on the coronary angiogram? We can vote by raising hands. So you trust CT more.
From what I saw in the CTA, like the PDA didn't show that it was really involved much with stenosis. So that 0.76 is just more of a cumulative effect with like vessel tapering rather than a true stenosis.
Right.
The FFR should be measured, I think, once you complete the distal stenosis.
Yeah, so maybe the 0.8.
And 0.8 is like a wish-wash community. And
Yeah.
It's a gray zone.
It's the cutoff.
in
Yeah.
FFR. So I really don't trust anything unless it's less than 0.7 on FFR.
Okay.
Plus the area where it's dropping is supplying very small amount of myocardium. So whether it's true or not, that's a different. But if there is a lesion which supplies little myocardium, you may potentially miss it by function.
I see.
And the other caveat, you guys know, for severe lesions, 1 out of 4, so 25% of those cases, you could have discrepant findings. So physiologically, it could not be significant, but anatomically, you're having a 70% lesion. So again, anatomy and physiology, they don't go along with each other all the time.
Right.
And I think Mahmoud raised a really good point where that intermediate is kind of like a coin toss. So if it's very low or very squarely in the normal range, then it's helpful. But that kind of intermediate is
But would you send him to cath or like?
depends on the symptoms.
Yeah. So the patient was complaining of chest pain all the time, especially on exertion. So we did send him to cath. And as we can see, we have some disease, but nothing significant in the LAD and the diagonals. Also in the circ and the OM1, it was called 30% in the OM1.
Is that mid-LAD looks right at the septal diag bifurcation? Does that look significant? Or did they do any physiological testing like IFR?
They didn't do IFR on
You
the.
see the lesion right before the second diag comes
Yeah.
out. There's looks like a 50%.
They called it 40 here.
Yeah, after the, yep.
Yeah, yeah. They called it 40%. They didn't do any IFR. Now I'm going to show you the right coronary artery. So this one, they called it 50 to 60%. They did IFR for this one, and it was negative 0.98. So the teaching points I wanted to highlight with this case is that false positive exist even with addition of FFR to coronary CTA. And I'm sharing this article from the next trial, which was used to evaluate the significance of adding FFR to the CT angiograms. And if we look at the positive predictive value of coronary CTA in patients, and this is in intermediate stenosis, having between 30 to 70% stenosis, and this is basically where we need the FFR for help. And if we look at it without having the FFR, the positive predictive value is only 37%, and when we add the FFR, it increases to 63%. So this says that in around 37% of patients, we can call it positive, but not really have any significant disease on invasive coronary angiogram. And the second thing I wanted to highlight from this case is basically the importance of PET in patients with severely elevated calcium scores, not only in diagnosis, but also in prognostication. And this is from the work of Dr. Arifai and Dr. Almalla. They took patients with severely elevated calcium scores and divided them into those between 400 to 999 and those with more than 1,000. And they stratified them based on the MFR, whether it was less or greater than 2. And in both groups, when the MFR was greater than 2, the incidence for having an event of death or MI was much less as compared to when the MFR was less than 2. And this effect was even more amplified in patients with calcium score more than 1,000. And now I'm going to leave it to Hatice for the second case.
Hi everyone, my name is Hatice. I am one of the CT fellows. Okay. So my patient is 52 years old male, presenting with chest pain and heaviness with physical activity. He doesn't have any risk factors. He's seen by outside cardiologist. He underwent extensive cardiac workup for this chest pain, including a normal cardiac PET with a calcium score of 0 and normal echocardiogram. He was started on some beta blockers and some PPIs for symptomatic relief, but patients continue to have symptoms, so this is why coronary CT angiogram ordered.
You know, the outside PET, did they do perfusion only, or they also added flows?
Only perfusion, I believe. Okay. And this is the coronary CT angiogram. Is there anyone to take what is wrong here?
Anomalous RCA.
Exactly. So, so there's an anomalous RCA coming from the left coronary cusp. RCA is dominant, and there's no any other coronary atherosclerosis or stenosis in other vessels. Sorry. So when we see this kind of coronary anomaly in CT, we look for high-risk features. Some of the features are highlighted here, like an interarterial course, meaning that the anomalous vessel course between the pulmonary artery and aorta. Intramural course, meaning that the anomalous artery courses inside the aortic wall, or acute takeoff, as seen here. Paroxysmal narrowing or elliptic vessel shape. As you see here, ostial RCA is narrow and with elliptical shape as compared to proximal RCA, and slits like ostium. Other than CT, other cardiac modalities also may help in these situations. For example, myocardial perfusion imaging studies may show stress perfusion defects, or cardiac MRI may show some patchy scar because of the burst of myocardial ischemia and fibrosis, which may serve a substrate for lethal arrhythmias in these cases. So keeping those features in mind, so let's look at our patients' images in detail. As you see here, this is the pulmonary artery and this is aorta.
Sorry, Hatice, you might
Yeah.
want to move the mouse cursor to the left of the screen to show the audience.
Okay. Is it, how can I do that?
So move it like as if you're having a third monitor.
So it's actually.
Now we can see.
I still, I didn't understand.
Bring it. Actually, it's to the right for some reason. See how it moves from here, and then goes.
Oh, it is just right there. Okay. Okay, so this is the pulmonary artery here, and this is the aorta. So as you see, there's an interarterial course. As you here, there's an intramural course. And you can see how the vessel having like acute like an takeoff angle here and here. And when you see the RCA ostium has a narrowed in an elliptical shape as compared to proximal RCA. And in these views, also you can see how the ostial and the proximal part is narrowed. So this is the CT report. Anomalous right coronary artery abnormally arises from the left sinus of Valsalva, where it tracks between the aorta and pulmonary artery, and high-risk features are present like intramural and interarterial course, elliptical proximal vessel shape, and acute angle takeoff. So when we, the learning point here is what to do next for this patient. So this figure is taken from the last guideline. When there's an anomalous aortic origin of the left coronary, the left coronary artery, if there's ischemic symptoms or if there's an abnormal stress study, these patients will undergo surgical intervention with a class 2A indication, class 1 indication. The same thing for the right coronary artery coming from the left sinus. If the patient has ischemic symptoms or abnormal stress testing, surgical intervention will be class 1 indication. For the left coronary artery, if patient doesn't have any ischemic symptoms or normal stress testing, but if the patient has high-risk findings, as we discussed in previous slides, still patient can go to surgical intervention with class 2A indication. For RCA, in the same scenario, surgical intervention will be 2B indication, or continuous observation is an option, also within 2B indication for these patients. The other point is what kind of stress test should be ordered. Exercise and since exercise and dopamine stress test reflects dynamic conditions better than vasodilator stress testing, exercise and dopamine stress testing combined with the imaging modalities, which could be echo, nuclear, or MRI, is preferred in these patients to assess ischemia and guide decision making. So patient underwent exercise cardiac PET with 518 fluperidas. The exercise protocol was Bruce protocol. He exercised for like 12 minutes, did almost 14 meds, and reached 89% of age predicted maximum heart rate. He mentioned about having chest pain in the final stage. Normal blood pressure and reported response noted, and no malignant arrhythmia seen. So this is the EKG part in the final stage. As you see here, there are some mild borderline changes in the inferior leads. And this is the perfusion imaging images, stress and rest. And there was no any perfusion defect. And this was the cardiac PET report.
Sorry, question, is it normal to see RV uptake with fluoroperides
Yes,
in both rest and stress?
yes, because of better spatial resolution. So no perfusion defect noted, but borderline EKG changes noted and chest pain at the final stage reported. After this result, patient seen by CT surgery and patient underwent surgery. When it comes to surgical approaches in these patients, this includes coronary unroofing with or without osteoplasty, coronary reimplantation or pulmonary translocation. Coronary artery bypass graft is reserved for patients with coexisting coronary artery disease. So this figure kind of shows the surgical, possible surgical interventions. So the A, as you see here, okay, this one. So here, the left coronary artery is coming from the right sinus, and you can see there's an intramural course here. There's a slit-like ostium here, and this is how the unroofing is done. Sometimes they may need to detach the commissures, but it is very important to resuspend and repair the commissures because one of the possible complications of unroofing is aortic regurgitation. But in this view, as you see here, the ostia is much better. But in some cases, this ostium may not be adequate, and still patients may have, still the pulmonary artery pressure on the proximal side of the vessel. So in those cases, reimplantation of the coronaries should be considered.
Sorry, one more question. Walk me through the decision making. If I have a relatively young patient with an excellent functional capacity, no arrhythmias, and no perfusion defect, what was the decision behind proceeding with surgery versus, watch and wait?
So I think my understanding is if it is left coronary is coming from the right, and if the patient has high-risk features on CT, still class 2A indication for a surgery. If it is right coronary artery though, if there's no symptoms or if the stress test is normal, even with high-risk features, it will be class 2B. I think it depends on maybe the surgery expertise in your center.
I thought the algorithm said ischemic symptoms, which he did have chest pain, right?
This patient, yes, this patient reports chest pain. Yeah, even in
Play soccer at
Soccer
10
player.
minutes, at 10 minutes every time.
Yeah.
Karen, and when he got to the 10 minutes, he dropped his STs. Although we didn't see perfusion defect, but was reproducible at the same time pain he gets on the field. So it's hard to the same recurrent pain every time
Yeah.
he goes for 10 minutes or so that he has to go out of the game. I mean, it's probably related to it, but again, we couldn't prove it by even perfusion imaging. We don't have blood flow exercise to even detect it earlier than like a perfusion.
Yeah.
They didn't try the medical therapy. They blocked it.
They already tried that, but because of the persistent symptoms, they ordered CTA. So this is the operation note from our patient. Again, the surgeon mentioned about an intramural course. First, he did unroofing, but at the end of the unroofing, the RCA was still facing to the PA. So this is why he decided to do a reimplantation. In the first attempt, though, after the first reimplantation, there was some EKG changes, like ischemic EKG changes and many PVCs. So this is why he disconnected the RCA and moved in a higher and a leftward position compared to the first reimplantation area. At the end of the surgery, the RCA was in a good position, good flows, and there was no any aortic regurgitation on the TEE. And this is the CTA after surgery to assess the new RCA. As you see here, RCA is now coming from close to its normal anatomic location. And there's no any proximal narrowing anymore. Yep, I think that's it.
Hi, good afternoon, everybody. So I'll carry on with the conference with presenting one of our cases where we also deployed sort of multi-modality correlation to arrive at, to aid decision making. So this is a 58-year-old gentleman who was transferred from an outside facility, having been resuscitated from an out-of-hospital cardiac arrest, said to be a shockable rhythm at the time. And in his sort of 10 to 14-day course at the other facility, he had intractable ventricular tachyarrhythmias. He had undergone 2 essentially tachyarrhythmia ablations in the less than 2-week period, and he had lots of other episodes where he was sort of AT paced out of it. His medical history demonstrates, some what we tend to call the traditional risk factors. Sorry, I'm just trying to get the cursor where it should be before we get to that stage. It's actually, oh yeah. So medical history shows sort of traditional risk factors for coronary artery disease and cardiovascular disease. And at the time that the conversation was had with us for transfer, he was basically on the zenith of medical therapy for ventricular tachyarrhythmias and still having very frequent PVCs. Now, his sinus rhythm ECG, sorry, I'm just trying to work this right. The cursor is a bit elusive. Yeah, so his sinus rhythm ECG is somewhat benign. There's normal intracardiac durations, and potentially as a purist, we would think that there's an element of intraventricular conduction delay, probably more prominent in the inferior leads, but doesn't raise any alarm bells. His tachyarrhythmia ECG shows unequivocal monomorphic ventricular tachycardia at a very fast rate, probably around 200 beats per minute. And at the time he got to us, he already had a defibrillator implanted, which is the 3rd ECG. Now he had a left heart cath at the other hospital, and it was reported as essentially showing normal coronaries. We don't have the images, and therefore I sort of tried to. When we look at the CT chest that he had here, I'm just going to do it on the screen. Oh yeah, done. We can see, as much as they are not gated and they are not, it's not a cardiac scan, but we can see that his LED is sort of well demonstrated. There's no obvious plaque there. It looks like a sizable vessel. And further afield, we can see a bit of the right and the circumflex, and essentially he has normal coronary arteries. Not like we disbelieve, but there's also evidence on this image. So he also had a cardiac MRI at the other facility, which was reported as highly suggestive of cardiac sarcoidosis, having been read by 3 independent readers. He had endomyocardial biopsy of the RV septum, which was negative for acute or chronic inflammation. On arrival, he had his echocardiogram with us, and this basically showed normal LV size and volumes, some element of akinesia in the sort of basal to mid septal segments, and effectively hypokinetic, globally hypokinetic ventricle, but no obvious etiologies to his presentation as seen on this echo. His ejection fraction is about 52%, and we can see a globally reduced strain with some sort of territoriality to it, where we have a much more reduced strain in the anterior and septal walls. He then undergoes a cardiac MRI scan here, and we see normal volumes. You can see his intracardiac leads in the right had normal volumes, possibly also lowish ejection fraction. Ejection fraction on cardiac MRI was reported at 50%. And then the leg gadolinium enhancement images show this sort of dense scar in the anterior and inferior walls, where in the anterior wall is quite distinctly subepicardial, well sparing the myocardium, and in the inferior walls, it's almost the same pattern where it's subepicardial, extends well into the mid-myocardial layer, but spares the subendocardium, and therefore a typical sort of non-coronary artery disease pattern. And in the sort of equivalent 3 and 4 chamber views, we can see that at the very basal end of the septum, it's transmural. So this was reported essentially as this dense scar in the septum, basal to mid-anterior walls and inferior walls, transmural at the basal segment. And the differential diagnosis at this point would be, could someone shout them out? It seems obvious. But I think we keep an open mind where, yes, everyone has thought of cardiac sarcoidosis, and this looks like cardiac sarcoidosis, but also it could be other things, and myocarditis, very bad myocarditis, could present this way, as could arrhythmogenic cardiomyopathy. So he undergoes an FDG PET, essentially 26 hours after the cardiac MRI, and we can see that, so we have sort of rest images on top, FDG images below, and we have the long axis images on top and the short axis images. So if we sort of start looking at the basal segments, we can see that there is a rest perfusion defect in the septum. There's reduced count in the septum, all of the septum, when compared to sort of the inferior and lateral walls. And there's absent count in the very basal anterior wall. And this sort of continues as we go further into the LV cavity, where we still have that reduced count in the anterior wall and a bit in the inferior septal wall and in the inferior wall. But as we go further into the septum, i.e. the mid-cavity level, there's a bit of perfusion defect in the septum and inferior wall, but it's sort of punctate and focal, and it's not in a distinct coronary artery distribution. Now, when we then focus on the FDG images, we can see uptake in the anterior, FDG uptake in the anterior and septal walls, but not necessarily in the inferior wall. And this pattern is maintained even as we go further into the mid and distal segments of the cavity. We have good, distinct FDG uptake in the anterior and septal walls, none in the inferior wall, and none in the lateral wall. And we can, this patient would, had adequate myocardial suppression prior to this study with beta hydroxy levels of about 0.6, and therefore certainly was well suppressed.
Question to you and the MRI readers in the room. This patient underwent the PPT ablation, subtracheal ablation in the past 2 weeks. Does the pattern on LGE uptake, can it be because of that ablation, or like how much specificity of LGE uptake can you have because of this myoablation patient?
That's way out of range for what you see with ablation. You hope that they don't burn the ventricle. That's way out of range. You could see it, but it would be very focused.
Small, like basal
much
septum.
smaller. This is like
And acute therapy BC ablation was focused on the septum.
It was a basal septum.
But then also the septum was just transmural. I don't know.
And also the target of the ablation, to target the myocardial epicardially, you have to access the pericardium. So if you have an epicardial focus of VT, then that can create, kind of a scar burden, but not as homogeneous and very intense signal. But most of VTs are usually endocardial. We have EP people over here. And most importantly is in the acute ablation setting, typically you're gonna see like kind of a transmural scar tissue, and a lot of the times you actually see like evidence of microvascular obstruction, because there's hard time for the gadolinium to go inside those areas that are ablated, because you're creating acute myocardial necrosis and an infarction type of pattern. So if you're imaging someone acutely within 24 hours or 48, typically you're going to see like a transmural, and then in the center you'll see like a black, which is kind of very similar to like a microvascular obstruction phenomenon.
And indeed, in the MRI report, it was mentioned that there is a focus in the very basal septum with the MVO appearance that was thought to be from the previous recent ablation. So then putting together his MRI images and FDG PET images obtained sort of 26 hours apart, we can see that his MRI images show this dense like gadolinium enhancement in the anterior and inferior wall, and his FDG PET images show focal FDG uptake in the anterior wall, largely the subepicardium, which completely mirrors in shape and extent what we see on the cardiac MRI leg gadolinium enhancement. However, we do not see the inferior wall LGE area take up FDG, and therefore the inferior wall leg gadolinium enhancement is not thought to be metabolically active and potentially does not contain active inflammation. And I've just put that arrow there just to highlight the fact that the inferior wall through the slices had no FDG uptake. And I think with this, so this study was read as an abnormal inflammatory study with, first of all, highlighting the perfusion defect, which shows areas of scar in the areas previously described, and then significant focal FDG uptake in the mid to basal anterior wall septum, total inflammatory burden of about 5%. And whilst there was uptake in those areas that well correlated with leg gadolinium enhancement on cardiac MRI, it was still thought to be lowish grade SUV counts, which is definitely abnormal, but not in the range as we would expect for acute active inflammation, but has been more often seen, especially in our lab, in patients with genetic cardiomyopathies, whom we know could have that pattern of leg gadolinium enhancement as well as undergo phases of active inflammation in their areas of genetic cardiomyopathy scar.
The patient wasn't like started on any steroids, like after the MRI where they started?
He was started on steroids.
That might also explain why the patient was bumped up.
Very true. Yes, it might. Very true. His LV function was 50%, and I think it's sort of interest to me that the EF correlated across all modalities and was approximately at 50%. And we know that the sort of PET volumes do not correlate with gold standard like MRI, but the EF nicely correlates, and he demonstrates it. Also, if we are, when doing an FDG PET study for a patient who may have acute myocardial inflammation or sarcoidosis, we look out for extra cardiac uptake. And this gentleman didn't have any areas of sort of pathological FDG uptake in keeping with sarcoidosis. He did have some around his ribs, but he had protracted CPR, and he probably was broken ribs healing.
So that kind of, like, you have so much active inflammation in the heart, like MRI or GP, that you have very low rate of FDG and have no extra cardiac. Usually in these kind of cases, you have a lot of nodes, extra cardiac, and the low grade, there is some discrepancy between these. That's what have alerted us in some cases that this could be not like the typical sarcoid inflammation, that this could be genetic cardiomyopathies in some cases. And we had our share of cases where it turned out to be genetic cardiomyopathy.
So we included that in the report, and with the intention that this is flags up at the clinical end so that genetic testing is done, especially as his primary reason for coming over here was actually to be screened for cardiac transplantation. I think this gentleman's journey sort of typifies. So the first graph is from ASNIC's sort of expert consensus statement on FDG PET imaging in patients with cardiac sarcoidosis. And it basically demonstrates that we are better able to prognosticate the patient's risk of high-risk events like ventricular tachyarrhythmias or sudden cardiac death, indeed, when we have a combination of rubidium perfusion images and FDG PET for metabolic activity. And whilst, our patient is not in this group of patients because he's already had his event, but we can see how people like him who have a resting perfusion defect and active FDG uptake would have very adverse outcomes. Now, that algorithm on the left is a study that was done by a group in Germany who basically looked at 43 patients with extra cardiac sarcoidosis and thought to combine FDG PET and cardiac MRI in the hybrid imaging to see whether we increase uptake, yield of cardiac sarcoidosis. And they were able to then discriminate the results into sort of 3 or 4 groups of patients where There are patients with cardiac sarcoidosis that have active inflammation, and they would have a positive late gadolinium enhancement on MRI and positive on PET, and they do have acute inflammation, acute inflammatory cardiac sarcoidosis. But there are also patients who have chronic inflammatory cardiac sarcoidosis where they have evidence of scar or late gadolinium enhancement, to be more sort of meticulous with the terminology, and negative PETs, which demonstrate that they do not have active inflammation. So we can see that our gentleman sort of was on this side of the table and sort of has tried these two groups, because his anterior wall certainly showed evidence of active inflammation, but his inferior wall is probably a silent, indolent scar process. And this study was able to demonstrate that by combining FDG PET imaging with MRI and amplifying the yield from MRI with parametric mapping, that they were actually even able to pick up some patients that had negative late gadolinium image and therefore were thought to be not have any evidence of cardiac sarcoidosis, but then the parametric mapping would actually demonstrate some elevation in T1 times and sort of interstitial fibrosis, demonstrating that these patients do have cardiac sarcoidosis. So I think this gentleman sort of sums up what we learn in the journey of cardiology about cardiac sarcoidosis being the master masquerader that can present in any and every way. His initial ECG, Dr. Nabi, did you want to say something? I thought you were raising your hand.
No. I was, I think, doing something else for that.
Sorry.
Are we sure we have cardiac sarcoidosis? I mean, now we're just basing this on.
Exactly. So I was going to say that the highest likelihood, we are treating him as the most likely diagnosis of cardiac sarcoidosis, but we do not have tissue diagnosis, and therefore we cannot say that he has cardiac sarcoidosis. He may well have a genetic cardiomyopathy and will be investigated along those lines. But we can see how his resting ECG was entirely silent, and therefore we couldn't have picked up clues from his ECG. His transthoracic echocardiogram may have passed through, did not raise any fluorid red flags apart from that sort of focal area of hypo and akinesia in the basal septum. But hybrid imaging amplifies what we can get and amplifies how much we can offer these patients in establishing a diagnosis, but also in following them up through the treatment journey, because this may become a lot more relevant as he then undergoes therapies and we see what becomes of his FDG activity over time and with therapies. I was happy to see that the EFs correlated, and certainly endomyocardial biopsy, tissue biopsy, and tissue diagnosis is sort of gold standard in the histological process, but we know that endomyocardial biopsy is often futile because of the focal and punctate nature of the process. And actually, hybrid PET-CMR imaging potentially certainly gives us a better diagnostic yield. Thank you.
Do you want to just call it here since we only have 10 minutes? Or if it's a quick case, we can go through.
It's the case.
Then maybe don't present it and we
Yeah.
We
So-
can take questions. I think, now.
Yeah.
Yeah, for the last case, I don't think we can call it cardiac sarcoid without a tissue diagnosis of sarcoid from somewhere or another. So it's either cardiac, lung, others, but I think at this stage I would still label it as either inflammatory or genetic cardiomyopathy, and we need some additional workup. Now, management-wise, yeah, you cannot leave the patient with VT storms. You need to treat them one way or the other. But diagnosis, I mean, it's hard for me to believe that you have so much damage in the myocardium, but no signs of extra cardiac sarcoid outside. It could be some people have called this as isolated cardiac sarcoid. In my opinion, there is nothing like, it's not isolated, it's just the first organ that presents. So if it is truly cardiac sarcoid, it will declare itself later. And usually it happens in middle-aged Caucasians. So usually Caucasians have very bad cardiac, and cardiac is the first organ to present. And then later on, they develop systemic manifestations of sarcoid. So instead of calling it isolated cardiac sarcoid,
just reading the chart, what were they planning?
So he's now been established on steroids. He's on guideline-directed medical therapy for heart failure. His primary reason for coming, for being transferred was for heart transplant, assessing for suitability. And I've just literally, a couple of minutes ago, someone put up the report that he's been turned down for transplant because it's too soon, and we have to see his response to the therapies. Yeah. So essentially, he's sort of under the care of the heart failure and myocardial diseases team, but he's been turned down for VAD or cardiac transplantation because it's too soon.
Because I think once, like, our people is pretty aggressive. Like, they can, wherever the scar is, they can, either go at the cardio or however they do it with robots, biopsy that side.
It's not about where you, like, to demonstrate non-caseating granuloma is another challenge, even when you biopsy the scar, because you could just get a fibrotic piece, and that has been the challenge. So it's very well known that the yield of biopsy is very good. But, I mean, we had cases where they had incessant disease, and I'm aware of at least 3 cases in our hospital here, that the first time that they demonstrated the non-caseating granuloma was when they were transplanted. So when they got transplanted, because we saw them after that for PET for CAP, when they got transplanted, they took out the heart, and they had multiple biopsies. And when they got the biopsy, when they got the explanted heart, the final diagnosis came out as cardiac sarcoidosis. They demonstrated the non-caseating granuloma. So, and like one of those patients I know for sure had like 3 biopsies, including voltage, the EP one. But all of them were called non-specific fibrosis. But the biggest question is that you cannot use the patient to make the diagnosis. So you have to treat them one way or the other. And they usually do not respond that well with just anti-arrhythmic. They need anti-arrhythmic plus anti-inflammatory for some cases.
Which effectively is what he is on heart failure therapies, antiarrhythmics, and anti-inflammatories.
But on the other hand, we had like a few months ago, similar case, and we wrote that statement in the report. It triggered genetic testing, and it turned out to be desmoplasma. So when you see this discrepancy between extensive LGE on the MRI, and less impressive PET, and no extra cardiac uptake, and low uptake from PET, and then you have no lymph nodes and others, think genetic cardiomyopathy. Genetic cardiomyopathies can give you low-grade inflammation.
Thank you.